Well, good afternoon. Welcome, everyone. On behalf of Cape Cod Healthcare and Emerald Physicians, I would like to welcome you to our Wellness Trails event. Wellness Trails is a series of educational events we do pretty much once a month. We've been doing it for more than a year and a half now, and a variety of topics are discussed. And so it is great that in such wonderful weather, so many of you chose to come in to listen to us. My name is Kumara Sidhartha. I'm a physician, medical director at Emerald Physicians. And today we'll be focusing on a healthy, resilient mind, behavioral health concerns, and how to care for ourselves with regard to our mind, better sleep, reducing stress, and understanding more about anxiety and depression. And so these topics that we choose are really chosen based on your feedback. When we do these events, after the event is over, we send a survey to the attendees. We ask for your input. And based on your input over the past year, we have come to realize what matters to you, what you are interested in learning more about, and that's how we choose these topics. So today's topic is one of those. And before we go into today's discussion, a few housekeeping notes. The restrooms are located across the upstairs lobby, and there are snacks and water. You can help yourself throughout the events. And for question and answers, if you want to ask a question to the speaker, I would ask that you wait until the speaker finishes the presentation so that you can ask at the end. And we may have to limit the number of questions depending upon how we are keeping up with the time. But we'll try to, keep on time today. I would also like to thank Julie Badok. Julie, could you please stand up and get a bow from everybody? Yeah. Julie does a fantastic job of organizing these events. She makes it look very easy, all the behind the scenes work. Thank you, Julie. And we have our clinical team members, Melissa, Sam, Rebecca, and Eilish, who are helping out with the blood pressure checks outside. Thank you to those team members. And we have Reese, who's always here to help out with the AV tech assistants from the center here. There will be an online survey we'll send out, like I told you, and please take time to fill it out, because we take time to read your input, read your feedback. It really helps us to co-create these events and deliver something that is valuable for you. So I think with that said, I think we'll move on to the first presentation, which will be on anxiety and depression, and I'll be speaking on that. So just to understand the scale of the problem with regard to anxiety and depression, you sometimes see recently also in the news, you're seeing suicides by celebrities, and that's just the tip of the iceberg that we're seeing. The underlying concerns, the underlying conditions, like the depression and anxiety, are very prevalent. There was a survey that was done which found that 1 in 5 patients who are presenting to a primary care office have depression, and 8% of these patients who present to a primary care office have anxiety disorder, which is technically called a generalized anxiety disorder. And this slide just shows the different elements or different types of disorders that are classified under depression and anxiety categories. So what we commonly refer to or think of as anxiety, when it's well established with a certain criteria, it's called generalized anxiety disorder, shortly GAD or GAD. Panic disorder is one which is categorized under this category. Agoraphobia is another one of the types of phobias. That's fear of open spaces, meeting with strangers, a social anxiety disorder, and there are other phobias that are categorized under that. In depression, what we commonly know and think of as depression when it's well established, it's called major depressive disorder. And then if depending upon the timeline or how long a person is having those depressed mood and symptoms, it can be categorized as dysthymia if it goes on for 2 years. And then depression can be part of what we know as bipolar disorder. And there are other co-occurring conditions which make the situation more complicated in terms of treating it, and also increases the risk associated with each one of those diseases. So PTSD is one of those, OCD is another one, eating disorders, and substance use, including alcohol use. So the risk factors for anxiety and depressive disorders, there is a lot of overlap with the risk factors, so I pulled them all together in this slide. An experience of a recent loss, a severe stressful life event. So life events that are negative and significant is one of the commonest things we see, and that leads to either anxiety or depression. And then a personal history of family history of so somebody who has a family member who has a behavioral health illness. And then chronic and major medical illnesses. In depression, anybody who has a history of stroke, heart attacks, cancer, diabetes, chronic pain, or AIDS, there is a strong correlation with them developing depression. And with regard to generalized anxiety disorder, all of these apply to that as well. The conditions that are listed for depression, and along with that, COPD, that is chronic obstructive pulmonary disease, which can be emphysema, chronic bronchitis, or migraines, high blood pressure, irritable bowel syndrome, chronic fatigue syndrome. So all of these, situations that significantly impact somebody's daily life can lead to either depression or anxiety. And we also find that in someone who has an unexplained physical symptoms, which has been worked up by multiple tests, seen by multiple specialists, and not getting an answer, that is another risk for anxiety or depression. A self-medicating behavior, whether it is alcohol, drugs, using sedatives for sleep, using diet pills, nicotine use, any of those sets up a risk factor for anxiety or depression. Gender, it's been found that both depression and anxiety are more common in women than men, and postpartum period is a risk, specific risk for depression among women. So, this slide, I just wanted to show that there is so much evidence now in terms of understanding the biochemical and physiological changes that happens in the brain in understanding anxiety and depression. Now we have a better understanding of which parts of the brain are involved in these. This scan is just showing it's showing the brain activity based on the heat mapping that you're seeing. In two locations, the PFC means prefrontal cortex. It's the front side of the brain, basically. And you could see that there is a difference when there is a low anxiety situation. The colors are different in terms of how the heat mapping is showing in these brain scans. So it's just a picture, but there are multiple other evidences showing that diseases like depression and anxiety there is a strong correlation with structural biochemical changes in the brain, and we have now pinned down which areas of the brain are connected to these conditions as well. So there are some fundamental processes that are involved in how we in the medical office screen for, look for depression and anxiety. And there are some standard screening questions that we use to identify if somebody has a risk for depression or anxiety, and then so that we can look further or explore that further. These two questions, if asking whether a person has found to have little interest or pleasure in doing things in the past 2 weeks, or feeling down, depressed, or hopeless in the past 2 weeks. So if they answer yes to any one of the questions, that kind of gives us a clue to look further into depressions. And then we go on to a set of 9 questions that we ask. These are standardized, valid tools we use to screen for depression. The same way for anxiety, generalized anxiety disorder, somebody is bothered by feeling worried, tense, or anxious much of the time for the past 6 months, or there is a frequent trouble of sleeping, experiencing fatigue, irritability, headaches, muscle aches, trembling in the past 6 months. If they say yes, then it triggers us to look into a next level of screening questionnaires. And now, there might be patients who have these symptoms of, feeling dizzy and fatigue and irritable and headaches, and it may be just a bad day. So we just need to differentiate that by going into the next level of testing by asking additional questions that helps us to distinguish from what is really an anxiety disorder from something that is just not, just a series of bad days. These are some of the signs and symptoms of anxiety disorder: excessive anxiety or worry occurring more days than not in the past 6 months. And the worry is about everyday matters. It's not related to a particular unusual situation or a particular unusual environment. And the worry is difficult to control. And then, in addition, 3 of the following is noted in this condition, where we call it GAD, or established anxiety disorder: either restlessness, feeling fatigued, difficulty concentrating, irritable mood, muscle tension, or sleep disturbance. So you would see that sleep comes. You'll notice that the sleep disorder comes in different angles when you talk about mental illness. And I think in not only that, any of the symptoms that I see in the primary care, whether I'm seeing a patient for asthma or emphysema, I may be seeing a patient for chronic pain, fibromyalgia, whatever it may be, any of those symptoms are made worse if somebody is not getting a restful sleep. And their anxiety, if somebody has anxiety, it's just made worse by not getting a restful sleep. So sleep is very fundamental in really helping us to recover and recharge and feel better. So that's why we actually chose to include one of the topics today to talk about sleep disorders and how can you manage sleep. And a lot of the times we end up using over-the-counter remedies for sleeping better, and we end up having more trouble with that than getting real solutions. So that topic is coming up right after I finish. So, and these are signs and symptoms of depression. Again, the criteria we use is to have these symptoms present for at least 2 weeks, having a depressed mood, and along with at least 4 of the following: loss of pleasure or interest in ordinary activities, feelings of guilt, worthlessness, or hopelessness, decreased energy, fatigue, unexplained aches, pains, difficulty concentrating, restlessness, irritability, again, sleep. It can be even oversleeping. It doesn't have to be a problem of not being able to sleep, falling asleep or staying asleep issues, but also oversleeping can be a sign of depression. Changes in appetite or weight, and thoughts of death or suicide. So if any of the 4 are present along with depressed mood for more than 2 weeks, that's really, we're thinking about major depression at that point. And dysthymia is basically very similar to what we just talked about, but the depressed mood is present for more days than not for at least 2 years, and with at least 2 of the symptoms that we just talked about here. The management is slightly different in that. And then the symptoms of bipolar depression, bipolar disorder is a condition of mood swings. The person can go through um, um, a overly high or irritable mood, which is called mania, and to being overly sad or hopeless, and that's the depression part. And it's important to differentiate between just straight up major depression from bipolar, because the treatment, again, especially if you're using pharmacological treatment, it needs to be carefully differentiated so that the choice of treatment can treat it accordingly. Otherwise, if you don't pay attention to that, um, giving certain medications during bipolar can without addressing the mania part, it can actually make it worse. So with regard to bipolar, the mania part, it's important to note that um, the person can have kind of grandiose delusions, racing thoughts and speech, extreme irritability, hyper energy, like unusual superhuman energy, and they're not tired. And that's a clue. Again, high risk behavior is another clue. Reckless behavior, poor judgment. It can be shown by spending sprees or high risk sexual behavior. When we see more of those coming together, we have to think about a bipolar depression. And then the onset of age is usually it can be starting at a younger age, less than 20 years. And this is something we encounter very commonly in primary care, is some of the medications that you're on and we start you on can sometimes mimic depression. Beta blockers, um, these are a type of blood pressure medication that can mimic depression. Again, I want to make sure that you understand this clearly. This doesn't cause depression. It doesn't create any biochemical changes in your brain to actually cause depression. It mimics the symptoms. It gives you that sluggishness, not wanting to take initiatives, not wanting to do the things you like to do. So it mimics the symptoms. Steroids can do that. This is like ranitidine. We don't use that anymore. And then oral contraceptives and, of course, sedatives and sleeping pills like Ativan, benzodiazepines. They can all mimic depression as well. And there are some medical conditions that can mimic depression. Thyroid conditions, when somebody has underactive thyroid or hypothyroid status, it can give the same symptoms. It's actually called, and technically we call it pseudo depression. It can mimic it. Alcohol use, dependence and withdrawal, stroke can cause symptoms that are mimicking depression. Diabetes, somebody whose sodium is off in their blood test, electrolyte disturbances. Cancer, Parkinson's disease is a classic one. Also in Parkinson's patients, they develop a muscle change. The tone of the muscles change, so they develop what's called as a mask face, so they don't show emotions in their facial muscles. So they have a flat effect in that sense. Vitamin deficiencies like B12, folate, HIV or AIDS disease, heavy metal poisoning, like lead poisoning, and certain types of epilepsy, especially the temporal lobe epilepsy, which can affect the emotional centers, can also mimic depression. So treatment really, when we focus on managing depression and anxiety, and we have a psychiatrist, Dr. Paula Kirby-Long, who's going to speak next on sleep, management of sleep, and we will also maybe have her wisdom shared with us on some of these areas while addressing that. But when in primary care, the first step when we approach a patient who has these concerns is to really look at how can we address, if something is changeable in their life, can that be changed to remove the stressors? The stressors can be managed. The stress can be removed. If the stress cannot be removed, then how can we teach them how to manage that around that? So a lot of that is cognitive, how we identify, understand, and change the thinking and behavior patterns, because um, we are not trying to remove the stressor here, because once we understand, okay, this stressor is something we can't change, so how do we react to it? Can we change that? And that's what this is all about. So cognitive behavioral therapy is a very standard treatment that is used. There are other types of therapies that are used in psychotherapy, acceptance and commitment therapy. Here, it utilizes the ideas and notions of acceptance and mindfulness techniques, along with commitment and behavior change in terms of coping with the sensations that comes as we deal with stressors. In what's called as DBT, or dialectical therapy, it again combines the cognitive behavioral therapy techniques along with meditation modalities. And the EMDR, which is called eye movement desensitization and reprocessing technique, that is something that was a very innovative, interesting discovery when the scientists found that rapid eye movements can actually impact how we react to disturbing thoughts. So just the way that the eyeballs are moving can create changes in how we react to certain disturbing thoughts and emotions. So that's been, since that finding, this has become a very standard treatment for PTSD, panic disorder, and different types of phobias. And of course, healthy lifestyle is very complementary. It may not by itself fix the problem, but it's a great complementary treatment to add to any kind of psychotherapy that's being done. Exercise has been shown repeatedly in many studies to help with anxiety and depression, and there is always a connection between food and mood. And when somebody is anxious, it's always good to maintain the blood sugars in an even keel, not to have the highs and lows in blood sugar. And that also helps with the mood. If somebody is eating, we have done this discussions in the past, high dietary fiber, including meals that are rich in dietary fiber, helps to maintain the intestinal health. And when the intestinal health is maintained well, your serotonin production is maintained well. Most of the serotonin works in the brain. More than 60% of the serotonin is produced from the gut. So and so it's important for us to keep the gut health well. And the commonest insult that comes to the intestines is through the choosing the wrong foods. So by making the right choice with regard to food, by increasing the dietary fiber, we are not only helping the intestinal health, but also helping the immune system, helping boost up the serotonin production, and it makes us feel good. And sleep is so fundamental, as I mentioned, and we're going to have a separate discussion about it today. We will also have we have a speaker today about talking about mindfulness and meditation, and there are other strategies which can be spiritual, music, humor, gratitude. All of that helps to cope with that, and they're complementary to the approaches we're using here. And with regard to pharmacological prescription remedies, these are very commonly used. I didn't list all of them, but the group called SSRI are selective serotonin reuptake inhibitors. Basically, what they do is they allow for the brain's connection areas to have a reasonably good amount of serotonin maintained. And that's the purpose of these medications. There are different categories in them that are used. And then came the what we call as SNRIs, the serotonin norepinephrine reuptake inhibitors. They also help with management of depression and anxiety, primarily here listed for anxiety. Now, if at all, this is something a cautionary mention here. Benzodiazepines, you might have heard of them as Ativan, lorazepam, Valium. Um, they are harmful if they're used beyond 6 weeks in the initial period. If somebody is in severe anxiety, it's okay to use it early on, but the goal is always to get the patient to a stage where they can be managed without benzodiazepines. It doesn't happen all the time. Sometimes you depend on that, um, but it's something we want to use less of whenever possible. And I think I'm just going to finish with the Serenity Prayer, which I always find very fascinating, very practical, especially if you can see the idea that we just need to learn to accept the things that we can not change, and the courage to change the things that we can, and just knowing the difference. So I find it fascinating when I first learned it. It's so applicable, practical. And so these are some resources. I think you have it in a printout. There might be there are one thing I didn't mention there is there is a website called psychologytoday.com. It's a great resource to find psychotherapists. So, for example, the different types of therapies that I mentioned, the cognitive behavioral therapy, for example. So if you go to the website, Psychology Today, you can put your zip code in where you live. It pulls up the list of all the therapists that are in that area. And then there are different filters that you can use to kind of zone in. So you can select the ones that do this cognitive behavioral therapy. You can, if you have Medicare or Blue Cross Blue Shield, you can select the ones who accept that insurance. So then it will show only the list that of people who accept your insurance. So it's a great tool to check out. And always, I mean, I always find that the senior centers in many of the towns are offering different types of meditation and yoga, and have speakers come and speak. So try to always make use of that, and that's going to be very useful too. I believe that's pretty much it. So yes. So the question was on personality disorders and ADHD, and asking where do they fall. I, Personality disorders are their own category, in my view, and then the ADHD is again, they don't fall into any one of these depression anxiety categories. So I didn't dive deep into that. The management for that is different. For the ADHD, there are prescription pharmacological managements available. A lot of the times, the complementary therapies like the mindfulness and the meditation, they help to augment the effect of the medications. Um, and for personality disorders, usually the different types of psychotherapy that was discussed, they are probably one of the best ways to address them. Yeah. Thank you for the question. Dr. Kerbelang, is there anything? If there's anything else you could add, you can let me know. Yeah.
Dr. Sidhartha, you talked about and you showed an MRI brain scan. But what about EEGs? And the reason I bring that up is this thing that's become fashionable with some people is the transcranial direct current stimulation. That is, they put the, I think downtown, I think at Israel has a specialist in that area, where you put the electrodes on your head and you can actually add direct current stimulation and lift mood, lift serotonin, and actually change other parts of your brain. You want to sleep, you stimulate a different part of your brain, and you can sleep. Can you comment on that?
Good question. I don't. Okay. Do you have any thoughts on that, Dr. Kerbelang? We need a mic here. Thanks.
Hi. There are two novel treatments for treatment-resistant depression. One is the ECT treatment, which has been around forever, from the 1930s, 1940s, where we actually use electrical currents to promote seizure in the brain to correct underlying brain chemistry abnormality. The transcranial treatments are not actually applying any kind of pulse to the brain. We're using electronics, a magnet, to change the spin of the electrons in the brain to affect improvements in mood. Usually used for treatment-resistant depression and can be used adjunctively with medication. There are specialized centers that do the transcranial as well as the ECT treatments in Boston.
Thank you.
Again, in reference to the brain scans, are there any facilities in the area that are doing any type of brain? I would love to see what my brain is doing.
So for the diagnosis purpose, brain scans are not needed. This is what I showed are done in research centers, trying to further understand what's happening in the brain. So for diagnosis, the simple questionnaires that I showed, that does a very good job in picking it up. So.
In terms of monitoring change or being able to evaluate how treatment is doing.
Yeah.
I remember being thrilled when I had to have a CAT scan because I could prove there was brain matter up there. So, you know, when you have physical proof that you can track with,
Especially change over time, then a baseline image that you can compare with other things. I've been coping with depression for over 20 years. So having baseline scans, I think, would have been helpful just to try to monitor change in the brain.
You're right, but I don't think we are there yet in terms of standardizing that and formalizing it and understanding the real value in going for a test like that to monitor. And I think I don't. It's because we have very good ways of diagnosing just with this standard approach of question and answers, and even monitoring the progress and improvement using the way the interactions between the provider and the patient. So the office setting itself provides a lot of the information that we need right now. So that's what we are going with. Yes, we will talk. Yeah.
Hello. Did the medical field recently discover that the gut is related to the brain, and that if you eat healthy foods, your brain should be healthy? I mean, I've been listening to that recently about, eating good food for your brain.
Yeah. So I don't know if everybody heard the question. The question was on the idea of the connections between gut and brain that's being discussed in these days. It's called the gut-brain hypothesis. The theory is that there are nervous system. There is a tremendous amount of nervous system that is in the intestinal design that we have. It's called the enteric nervous system, and there is now understanding of how exposure to certain foods, let's say high dietary fiber foods, helps to harmonize and normalize the nervous system, calm the nervous system in the gut, and send the correct feedback messages to the brain, to the higher center, which kind of regulates how our appetite functions work. The turn off switch when we don't have to have the appetite. How the inflammatory signals work. The inflammation signals from the brain are connected to the signals that come from the gut. So a lot of it, it's being discovered now in a big way, and also the role of the good bacteria in the gut is also a huge deal now, and we're still trying to understand that better in science. And that is also connected to depression and inflammation, the amount of good bacteria in the gut. So it's a very important and exciting area of research that's undergoing. Yeah. One more.
Is there any food that should be eaten or can be eaten prior to going to bed to sleep that is helpful in getting you to sleep and giving you a sound sleep?
So the question was, is there any particular food that is helpful to eat before you go to sleep well? It's kiwi fruit. Kiwi fruit, yeah, kiwi fruit. So there has been only one small randomized control trial that has been done that uses kiwi fruit. And what they did was they took, I believe, 30 folks, and they divided them into two groups. And one of the groups got 2 kiwi fruit every night, 1 hour before they go to bed. And the other group did, otherwise the groups were comparable in the sense. And the sleep quality, duration, and the latency period was measured using standardized sleep index measures. And they found that those who ate the kiwi fruit had better numbers in terms of the sleep index. And it is believed that because kiwi fruit is a rich source of tryptophan, and the tryptophan gets converted into serotonin, which is what is believed to be the reason for. I don't have stocks in kiwi fruit, just so you know. We have one more question, yeah.
For someone that has,
I'm sorry. Okay, I'll come back to you.
Oh.
Yes.
for someone that has been on an SSRI inhibitor for a long time, would it be better for them to have ECT therapy to offset any side effects from medication, and how and with whom should that be determined?
Could you please, I just found where you are. I was like trying to figure out where you are. All right. So this is a question. Do you have an answer for the question, Dr. Kabilan? Do you mind repeating the question, please?
For someone that has been on an SSRI inhibitor for a long time, would ECT therapy be an option to eliminate the side effects from that medication, and how and with whom would that be determined?
So we wouldn't use ECT to improve or decrease side effects from medication. Sometimes ECT is used to adjunct medication therapy if the depression is not completely treated, or sometimes people substitute ECT treatment for medications themselves. They may be on a course of maintenance ECT going every 3 weeks, every 4 weeks to maintain their mood without medication. That should be discussed with a psychiatry person, somebody who specializes in mood disorders, and it's, again, the ECT is the most effective treatment for treatment-resistant depression, but it's not easy therapy. It involves going to a hospital setting. You have anesthesia to get through the ECT treatments, so it should be discussed with a psychiatrist, in my opinion.
Thank you. Thank you. You got a question?
Yeah.
And this is going to be the last question, yeah.
I found with my situation in food, if I get
I will repeat the question.
okay. I find that when I'm into my junk food, sugar, white flour, and all that, that can cause a depression. And when I get off it, I'm totally different.
Mm-hmm.
And it's almost like alcohol to my brain.
Yeah. Yeah, absolutely.
Do you agree with that?
Yeah, totally. So all the processed food, the sugary foods, all of them are affecting the gut in many different ways. But one of the ways it's affecting is affecting the gut bacteria that I talked about, and also it affects the insulin balance in the body because of the too much sugar coming in, and that can create highs and lows in the blood sugar, which the brain. The brain is so fragile from the perspective of your blood sugar level. If your blood sugar is not steady and even keel, the brain goes through so many challenges. And brain is where all of this serotonin and all of this is working to create a mood. Even though brain is only 2% of your body weight, it consumes 25% of the carbohydrates that we eat. Brain is only 2% of your body weight. For an average adult's body weight, only 2% of the body weight is contributed by brain, but it consumes 25% of the carbohydrates that we eat. That's because the only fuel that can enter the brain cells is carbohydrates. Fats and proteins cannot enter the brain. That's how the brain is built. There is something called a blood-brain barrier. It's like a door that's blocking, and protein and fats do not have the password to enter. Only carbohydrates has the password to get into the brain, which means brain totally depends only on carbohydrates, and any fluctuations in carbohydrates can have a tremendous effect on how the brain cells are functioning. So when there's too much sugar coming in and the sugar swings are happening, it just throws off the brain. And I've said this many times in the past, and that's one of the reasons. When the blood sugars are off in a person, that leads to prediabetes and type 2 diabetes. It leads to eventually Alzheimer's disease, which is now called type 3 diabetes. So it's so important to manage the sugar in a better way. So thank you so much. We have to move on to the next speaker. So I appreciate your interest and engagement.